Good morning.
Hello, this is Janet McTaggart, and we're here to present a case study. The topic is complications in type 2 diabetes, diabetic ketoacidosis.
Hello, my name is Kawana Gaffney DeVoe.
And I'm Jasmine Brooks. Enjoy the presentation.
Okay. Diabetic ketoacidosis is a serious complication of diabetes that can lead to coma or death. It results from a buildup of ketones in the blood due to insufficient insulin to use glucose. This case study is about a patient, Tracy. She's 37 years old, African American female. She's got a history of diabetes. She's HIV positive. She has a history of crack cocaine abuse. She has asthma. She is non-compliant with her medication. And she has depression due to recurrent hospitalizations from the diabetic ketoacidosis. So Tracy presented to the hospital with nausea, vomiting, and weakness that she's been having times 2 days. She states she has not eaten in 2 days. On admission, Tracy's vital signs were the heart rate 77, blood pressure 110/67, her respiratory rate 18, blood sugar level 750, pH 7.25, bicarbonate 15, anion gap 33, bilateral breath sounds were clear to auscultation and diminished in the bases, and the saturations 97% on room air. She has +2 pulses on the right and left radial arteries and +2 pulses on the right and left pedal arteries. She has moderate strength in her bilateral upper extremities and weakness in her bilateral lower extremities. She has no edema, and her abdomen is non-distended and soft to touch. Tracy has a past medical history of asthma, diabetes, HIV with a CD4 count of 7, and crack cocaine abuse. She has allergies to Zofran, Tramadol, and Percocet. Her home meds consist of 70/30 insulin, Incetrus, Truvada, Retrover, Albuterol, and Atrovent. Tracy is a frequent flyer who is non-compliant with her medications. So, on assessment, Tracy's blood pressure was 110/67, heart rate 77, respirations 18, her blood glucose was 750, pH 7.25, bicarbonate 15, anion gap 33. She had nausea, vomiting, weakness. The doctor has prescribed for Tracy insulin, intravenous fluid to correct the acid-base imbalance, antiretroviral meds, bronchial dilator, and nutritional supplement. So stage 1 assessment is her diabetes history, medication non-compliance, frequent hospital visits, and she has a low body weight. The nursing interventions are to assess the level of consciousness, interview the patient and obtain a health history, encourage fluid intake, administer insulin and IV fluids, monitor labs such as the blood glucose, ketones, and electrolytes, educate about the importance of medication adherence, arrange psychological support, and arrange a dietary consult. So, questions for stage 1. Which of the following would not be associated with diabetic ketoacidosis? Blood glucose of 250 or less, a large anion gap, nausea and vomiting, arterial pH of 7.25. And question 2, how does diabetic ketoacidosis affect her psychological well-being? Question 3, what is a nursing diagnosis associated with this scenario? The answers to question 1 is blood glucose of 250 or less. Question 2 answer is increased risk for depression due to diabetes. And question 3, ineffective self-health management is the nursing diagnosis.
Stage 2. Tracy is admitted to the intensive care unit and started on the insulin drip. Her vital signs are as follows. Her heart rate is 78, respirations are 16, her blood pressure is 110/60, her anion gap is 23, her pH is 7.25, and bicarb is 14. She started on an insulin drip at a set rate. Her blood sugars are taken every hour. She has Q4 BMPs. She's NPO. The physician orders not to adjust or change the insulin drip rate without an order, and if the serum glucose is less than 200, the gap is less than 16, and the bicarb is greater than 18, feed patient. Discontinue maintenance IV fluids 2 hours after sub-Q insulin. Pathophysiology of DKA. DKA is an acute major life-threatening complication of diabetes. It mainly occurs in patients with type 1 diabetes, but it is not uncommon in some patients with type 2 diabetes. This condition is a complex, disordered metabolic state characterized by hyperglycemia, ketoacidosis, and ketonuria. Physician's orders. As I stated earlier, she started on an insulin drip at a set rate. Her blood sugars are taken every hour. Her BMPs are Q4. She's NPO. We are not to change the rate without a practitioner's order. If the glucose is less than 200, the gap less than 16, bicarb greater than 18, feed the patient, and discontinue IV fluids 2 hours after sub-Q insulin. Tracy's labs. Her blood sugars were taken every hour. At 10, it was 350, 11, 300, 12, 289, 1 o'clock, 250, 2 o'clock, 200, and 4 o'clock, 200. Her gap at 12 was 14, her bicarb 23, pH 7.35, and 4 hours later, her gap was 15, her bicarb 22, and pH was 7.40. So at this point, Tracy's gap was closed ×2. She was given a sandwich and tolerated it well. Her insulin drip was stopped 2 hours afterwards, so it was stopped at 6 o'clock. She was placed on a diabetic diet, and blood sugars are taken 3 times a day with meals and nightly. Nursing interventions for DKA. There's a risk for fluid volume deficit, meaning that the patient is at risk for experiencing vascular, cellular, or intracellular dehydration. This can be assessed by testing the skin turgor, mucous membranes, and thirst. We monitor hourly intake and output. Knowledge deficit. Knowing your normal blood glucose level, the risk factors associated with DKA, the type of diabetes, and the relationship between an elevated glucose level and insulin deficiency. The third one is imbalanced nutrition. That's an intake of nutrients insufficient to meet metabolic needs. You must determine the client's dietary program and usual pattern. Recognize deficits and deviations from therapeutic needs. Monitor weight daily or as indicated, and recognize signs of hypoglycemia. Questions. I am an acute major life-threatening complication of diabetes that mainly occurs in patients with type 1 diabetes, but it is not uncommon in some patients with type 2 diabetes. This condition is a complex disordered metabolic state characterized by hyperglycemia, ketoacidosis, and ketonuria. What am I? Question 2. What are the signs and symptoms of DKA? The answer to question 1 is DKA. The answer to question 2, fever, coughing, chills, chest pain, dyspnea, and arthralgia.
So stage 3. At this point, Tracy is heading home from the hospital. She's being discharged. So we have the diabetes educator to come in and consult with her about proper type 2 diabetes management techniques. She's also discharged with a new set of medications. Before she was on 70/30 insulin. Now she's on regular insulin with a sliding scale and Lantus. Case management also came and consulted Tracy about HIV/AIDS outreach support groups and addiction rehabilitation centers. Because her noncompliance and her with the HIV/AIDS diagnosis, because evidence about her CD4 count of, I think it was 7, we need to focus on that as well. So Tracy makes the goal to take charge of her health and maintain drug-free. So after 3 months, Tracy comes in for a follow-up visit. So she admits to a relapse of drug use for one time, but she still says that she's managing her diabetes and taking her heart therapy. So let's think critically. So what laboratory results would we expect to see improvement in? So she's been doing what she was supposed to do. Let's see. What level should increase and what level should decrease? Question 2. What part of her lifestyle or history affects the effectiveness of her health regimen? So let's think about it. So as far as lab results, you could have said her hemoglobin A1C should be down if she's measuring her diabetes well. Her gap should be decreased. It should be really low or no ketones in her urine, no glucose in her urine. The pH level should be up in normal range, and her CD4 count should be increased. So as far as the her history that could affect her diagnosis is her drug abuse, her noncompliance, and her dietary habits. So many factors can influence the management, your health management. You just have to properly assess your patients and follow up and see what their needs are so you can continue to educate and provide what you need for them. So stage 3 continued. Her assessment. So her vital signs is in normal limits. 120/80 is her temperature. Is her blood pressure. Her temperature is 98.0. Heart rate is 65. Respiration should be 18. And her O2 status 99%. Her A1C is 6.7, so it did come down. Her pH is 7.38. Bicarb is 38. CD4 count has been significantly elevated at 305. The AN gap is 9. And her urinalysis, ketones negative and glucose negative. So interventions. We're going to develop long-term and short-term goals with Tracy. So short-term goals could be for her maybe changing a meal each day on what she eats. Long-term goals should be maintaining drug-free, also keeping up with her diabetes. And she has to adopt a personalized approach to her diabetes care. So this could be teaching her sliding scale, teaching her injection sites and the ways to inject, diet and exercise, as well as teaching methods as well. And let's evaluate our resources. So we need to know what Tracy needs, how we need to help her. So this includes the HIV/AIDS outreach programs, the addiction help, and let her stay drug-free and with everything. So here are our references. Continue, and thank you.
Thank you.